So I'm going to preface everything I say in this talk by saying that echo is, of course, central to imaging in heart failure, the cornerstone of imaging and diagnosis. However, it does have some limitations, sometimes image quality, sometimes reproducibility, and some somewhat limited information about the etiology of heart failure. And for that reason, over the past few years, a real change that we've seen, particularly in the UK, is a move towards increasing use of cardiac MRI in imaging for heart failure. And that is an early use of MRI scanning, so using it early in the diagnostic pathway, and using it in many patients instead of coronary angiography. So I'm going to explore a bit behind the reasons that we do that, and then show some cases which will hopefully support that approach and provide just something to understand that a little bit more. So MRI is not currently recommended in international guidelines as a first-line test for the evaluation of patients, but it is recommended as a second-line test in selected patients. I know some people have more access and more experience with MRI than others, but I thought it would be useful to just look a bit, first of all, about what it tells us, what we're looking for, some evidence and some emerging evidence, how the field, I think, is likely to progress, as well as looking at a case or two, depending on time. So first of all, what does MRI tell us? So we tend to divide this into function, scar, perfusion for patients with heart failure. Now, left ventricular function, we acquire a series of slices through the left ventricle from the base of the heart at the level of the mitral valve down to the apex. We then draw circles around the endocardium, which is shown in this top moving image here, black circles, and work out slices and calculate volumes and ejection fraction from that. So the slices are shown on the bottom there. And what that does is it eliminates any geometric assumptions that you might make about the shape of the LV, which are usually present when calculating ejection fraction and volumes with echo, for example, using Simpson's method. The advantage of that is that calculating volumes and ejection fraction by MRI tends to be much more reproducible than using echo, and we've known for a long time that that is the case. There's less inter-study variability, and therefore fewer patients, more accurate reporting of individual patients, and fewer patients are often needed for studies using MRI. So when studies using MRI are presented, you'll often see that the numbers tend to be relatively low for that reason. But really, the current jewel in the crown of MR imaging in heart failure is scar imaging. So patients are given gadolinium-based contrast, and a period of time is then allowed to pass, usually about 10 minutes. The vast majority of that contrast washes out of normal myocardium after 10 minutes. However, abnormal myocardium tends to retain gadolinium by two mechanisms. Firstly, increased volume of distribution, so there's more space for the gadolinium contrast to enter. And secondly, reduced blood supply means that gadolinium is slower washing out. So an acute infarction in the middle there, cell membrane integrity is lost, gadolinium leaks into the cells, and there's a higher concentration. As the infarct becomes chronic, the cells are replaced by fibrosis, and so there's more volume for the gadolinium to distribute itself within, and the reduced blood supply means it's slower to wash out. And really, recognizing different patterns of scar provides us with information that no other imaging modality has been able to rival. Here are some examples of non-ischemic cardiomyopathies. So top left, the normal myocardium is black. Heart looks a bit hypertrophied, but there's no scar. So these are a variety of cardiomyopathies, and B is an infralateral myocardial infarction. So every time myocardial infarction is imaged on MRI scanning, the scar starts at the subendocardium and works its way out towards the epicardium to a variable extent. So it's typical for ischemic etiology of scar and will differentiate ischemic heart disease as a cause of heart failure from any other causes. What we're learning to do is understand the various patterns of scar. So as we do more and more MRI imaging, we're recognizing different patterns and what they mean, and what that means for the patient in terms of diagnosis, prognosis, and management. So C is actually a patient with hypertrophic cardiomyopathy. You can see there's some scar in both superior and inferior RV insertion points. It's actually pretty common to see scar in those areas, even in patients who don't appear to have much else in the way of other pathology, just for example, hypertension or diabetes. For some reason, the basal infralateral wall seems particularly prone to scar, and D is a patient who's had myocarditis before, and you see this typical subepicardial, bright area of late gadolinium enhancement. In E, you can see papillary muscle infarction after sarcoid. Next to that, there's an example of severe hypertrophic cardiomyopathy, lots of hypertrophy, lots of scar. In H, we can see that there is late gadolinium enhancement affecting the RV wall as well as the infralateral wall, and this is a case of ARVC, and we're increasingly recognizing LV involvement in patients with ARVC because of more MRI imaging. So the advantage of this over nuclear imaging is really increased spatial resolution. So this is now an old study, but just to emphasize the point that SPECT imaging can of course visualize scar, but increased spatial resolution with MRI means that we can recognize patterns of disease that we haven't been able to recognize from nuclear imaging, and that's been validated in animal studies. So in ischemic heart disease, one test we're commonly doing is looking for viability, and this slide shows a number of different patterns of myocardial infarction, and we'll just look at how transmural that myocardial infarct is and categorize patients into quartiles depending on the extent of late gadolinium enhancement. Why is that important? Well, again, animal studies have shown us that the extent of late gadolinium enhancement, the transmural estate extent, correlates with how likely that left ventricular myocardium is to recover after revascularization. And again, old data, but seminal study, which has shown that if you have no scar, there's a very good chance that will recover with revascularization. Once you get above 50%, there's very little chance that that myocardium will recover. The role of revascularization in patients with viability obviously remains still something, an issue open for debate. And here's an example of perfusion imaging. So when we give our contrast, we give it as a bolus at the same time as vasodilator stress. So blood supply to the myocardium is maximized. Normal myocardium shows up as white, and areas of myocardium with severe stenoses, the inflow of blood and hence contrast is delayed, and that shows up as a black area, which you could see there in the inferior wall. So there's also an awful lot of other information we can get from cardiac MRI imaging in heart failure, as listed there, and I won't go through that in huge amounts of detail. So, as I said, we're frequently now using MRI instead of angiography to delineate the etiology of heart failure, which is important because it will influence our management. Are we justified in doing that? Well, there's increasing data really supporting that as a strategy. The initial studies looked at patients with heart failure of unknown etiology. They had MRIs and coronary angiography. And what that showed is that patients who had coronary artery disease as a cause of their heart failure almost invariably had late gadolinium enhancement, so almost always had some scar. There have been some studies showing that perhaps there's a small percentage of patients who don't, but you'd expect to see scar if the etiology of heart failure is ischemic. Now, of the patients with dilated cardiomyopathy, around 2/3 will have no scar, and many of the, around 28% in this study had this characteristic mid-wall stripe in the septum. Interestingly, a sizable proportion of those patients with normal coronaries had scar in the pattern of a myocardial infarction, showing that they'd had a previous infarct despite normal coronaries, presumably with recanalization or due to an embolus. So more recently, this is a British paper where 120 consecutive patients had both an MRI scan and a coronary angiogram. They had heart failure, and the question was, what was the cause of the heart failure? There were 3 groups of investigators. One group got to look at just the MRI scan, one group got to look at just the angiogram, and one group got to look at both. And the study was set up to investigate whether cardiac MR was not inferior to angiography for identifying patients who had an ischemic origin to their heart failure. These patients had function, so LV function, scar, and also a coronary angiogram of just the proximal coronaries. And this study demonstrated that MRI was very effective, was not inferior to angiography for identifying an ischemic origin, and at least in a UK setup, was a cost-effective strategy. Now, they did look at the proximal coronary arteries in this study because there was a suggestion from previous work that very occasionally you'll get a patient with ischemic heart disease causing heart failure with no scar on the MRI scan. And it was felt to be important not to miss severe proximal coronary disease in patients who didn't have any scar. However, in this study, they didn't have to use that proximal coronary angiography to identify patients with an ischemic etiology. So this is a more recent study again, trying to look at what impact does doing an MRI scan in patients with heart failure have on management and decision making. So this was an American study. They took 150 consecutive patients with an ejection fraction of less than 50% who were referred for an MRI scan to investigate the etiology of their LV dysfunction. They just did a standard MRI scan, so they just looked at function and scar. There was no perfusion imaging, no coronary angiography done in these patients. And I'll show you a bit more detail about the findings here. So they predefined what a significant clinical impact was. They divided that into how often could they make a new diagnosis and how often could they change a patient's management. It's a complicated slide, but changing the management really meant changing hospitalization, changing medications, having a procedure that they otherwise wouldn't have had, or avoiding a procedure such as an angiogram or revascularization that they otherwise would have had. And this is a summary of their results. So the important things I would take from this are that they were able to classify more causes of cardiomyopathy into either ischemic or non-ischemic causes, such as previous myocarditis. Ruling thrombus in or out often can be difficult with echo, and they were able to do so in a number of patients and then thus affect drug therapy. And what they and they divided these, they showed that in 65% of patients who were referred for an MRI scan, they felt that made a significant impact on their clinical management, as subdivided here. So a new diagnosis in around a third of the patients. The presence of late gadolinium enhancement was the best predictor of a significant clinical impact following a cardiac MRI scan, which is not really surprising given what I outlined before about scar imaging and its use, and the fact that that's something we can really just get from MRI scanning. Now this was an American study. It was a single center, and they just looked at patients who were referred for MRI scanning. So no question there will have been a significant selection bias, and I suspect this overestimates the magnitude of benefit that you're likely to get from MRI scanning. And to address that, there's a study called Outsmart Heart Failure, which is a Canadian and Finnish study randomizing patients to routine use of cardiac MRI in the investigation of patients with heart failure versus selected use. They're planning on enrolling 500 patients, and that study will be due to report next year. And I think that will be a very important study going forward in terms of defining exactly how we use cardiac MRI. We know that patients who have late gadolinium enhancement are, that's a poor prognostic sign. They're at increased risk of cardiovascular events. So this is another recent study looking at the association of fibrosis as defined by late gadolinium enhancement with mortality and sudden cardiac death in patients who had specifically had a non-ischemic cardiomyopathy. So this was a UK study of 500 patients. Of those 500, 140 had late gadolinium enhancement. So these were all patients with non-ischemic heart failure. And what they found was, even after adjusting for ejection fraction and other conventional prognostic markers, both the presence and the extent of fibrosis was an independent predictor of all-cause mortality. So we're getting independent prognostic data from MRI in these patients. And I think that is important because at the moment, current guidelines for ICD implantation to prevent sudden cardiac death are really based around measuring an ejection fraction. And we know that most patients with heart failure who have a sudden cardiac death don't have an ejection fraction below 30%, just because of the numbers involved. Whilst your risk goes down as your ejection fraction goes up, just the fact that more patients have an ejection fraction above 30% means that more deaths occur in that group. And many patients with an ejection fraction below 35% won't die from sudden cardiac death. So any refinement of that risk stratification in terms of selecting patients for ICD and so forth, I think would be extremely valuable. So this just shows the mortality difference between the two groups. And in the mortality during follow-up was 27% in patients who had SCAR and 11% who didn't, which is an absolute risk reduction of 26%. And patients who died had a post-mortem. This is an example showing that the late GAD on the MRI image correlates very closely with the fibrosis found macroscopically and microscopically. So I'm going to show you a case. This is a patient that I saw fairly recently who presented via the heart failure clinic. He was 52 years old at the time, and he just had 2 weeks of heart failure symptoms, so breathlessness predominantly, some tiredness, some edema, but no chest pain. Angina was not a feature. He'd not been unwell in the past, but he'd lived a good life. He'd smoked a lot. He'd drunk a lot of alcohol. Here's his echocardiogram showing that he really had very poor left ventricular function, significant amounts of functional mitral regurgitation. So at that point, to me at least, it wasn't clear what the etiology of his heart failure was. Was this a non-ischemic dilated cardiomyopathy? He'd not had angina, he had drunk a lot of alcohol. Or could this be an ischemic heart disease? Of course, he had risk factors. He's male, he's in his 50s, and had been a heavy smoker. So the options at that point, well, I think everyone would treat this patient for heart failure with proven medical therapy. Further investigations, certainly I would want to investigate further to try and work out what the cause of his heart failure was. And so options would be an angiogram, maybe a CT coronary angiogram, or a cardiac MRI. And because really this extra information we get for cardiac MRI, that tends to be the investigation of choice that I would opt for next. Here's his MRI scan really confirming a dilated and poor left ventricle. This patient actually had perfusion imaging as well as late gadolinium enhancement, just because of his risk factors for coronary disease. The top line here is the stress imaging, and I think that probably projects pretty well. You can see that there's a clear defect in perfusion in the lateral wall. That's the easiest to see. Also in the inferior wall, perfusion slow, and probably going around into the septum as well. Scar imaging showed that he has, can't point it out, but I don't know how well that projects, but he's got a thin layer of scar down the septum, in the inferior wall and in the lateral wall, but all of it is less than 25 or certainly less than 50% thickness. The report really reflected what I just told you, and the conclusion from the cardiologist reporting the scan was that the patient had substantial hibernation, and this was felt to be an ischemic cardiomyopathy mimicking a dilated cardiomyopathy. So on that basis, he had an angiogram, which I've shown here. And he does have significant coronary disease. As you can see, the circumflex and the right are subtotally occluded. There's some significant disease in an intermediate and probably at least moderate disease in an LAD. So on that basis, I was able to make a diagnosis of an ischemic cardiomyopathy, and having discussed him in a multidisciplinary forum with the heart team, despite the absence of angina, send him for bypass surgery. Now this patient then went on to go into a study, which was quite fortunate for me because it meant he got another MRI scan, and 6 weeks after bypass surgery, so really pretty early after surgery, there was a significant change in his heart, as shown here. The LV function improved with his ejection fraction going from 22 to 41%. The left ventricle got smaller, and RV function also improved, and mitral regurgitation reduced. And that was coupled by functional improvements. We had a patient who'd not been able to work because of his severe symptoms, who became unlimited when to NY Class 1 was able to resume working. So that's a pretty common sort of situation. Obviously, ischemic heart disease, two slightly more esoteric cases, one of which has decided not to play, but these were patients who, again, came via the heart failure clinics that we run and had echoes showing concentric left ventricular hypertrophy and diastolic heart failure, really, heart failure with preserved ejection fraction. Both the echoes look very similar, as did the cine imaging on cardiac MRI, but with the useful addition of late gadolinium enhancement. The first image on the left really shows that the myocardium, instead of being nice and black, is all white, and that is because there's so much gadolinium in the myocardium that you can't find any normal myocardium, and that's typical for amyloid, whereas the patient on the right had just a small bit of scar in the infralateral wall in association with his LVH, and actually turned out to be a case of Anderson-Fabry disease. So unusual, rare causes of cardiomyopathy, but a nice illustration of how we could differentiate that by using MRI early in these patients. So looking forward, the future of MRI imaging in heart failure. Well, this technique called T1 mapping is currently causing huge excitement in cardiac MRI communities. Obviously, there are a bunch of people who are fairly easily excited, but for those people who are not very familiar with MR terminology, T1 relaxation is a fundamental property of tissues and how they behave in a magnet. When patients are put in a strong magnet, all the hydrogen ions line up in one direction. The patient is then given a radio frequency pulse, which causes the hydrogen ions to come out of alignment, and as they come back into alignment, that's called the relaxation time, and that can be measured in various different ways. So the T1 relaxation time is an inherent property of the tissue and is largely determined by how much water makes up that tissue. And that's what gives patients in an MRI scanner natural contrast between different tissues. So even before giving contrast, there's a big difference between the endocardium and the blood, and that's one of the strengths of MR scanning compared to echo sometimes, when the endocardium can be hard to define. Now, what we've noticed is that T1 time lengthens with interstitial expansion caused by edema, infarction, amyloid, for example, and predominantly fibrosis, which is felt to be because of increased water in the tissue in those conditions. So what that potentially provides us with is a mechanism of recognizing cardiomyopathies that we can't see by late gadolinium enhancement, because as that case of amyloid showed that I put up, in order to recognize abnormal myocardium, you need to have an area of normal myocardium to compare it to. But if you're measuring an inherent property of the myocardium, then that may, even if that's diffusely abnormal, so abnormal throughout the myocardium, the anticipation is that your T1 value will change. And as I said, that's caused much excitement, huge numbers of studies going on using this, and there has been some limited validation of this technique against histology. And in some diseases, it's proven to be extremely useful. So in patients with amyloid, the T1 value is usually so far removed from a normal T1 value that you can confidently make a diagnosis of amyloid from a T1 study. And equally, Anderson-Fabry disease goes the other way, so they get fat deposition in the heart. The T1 value becomes very short, and equally that differentiates patients with Anderson-Fabry disease. The T1 times are very different to patients with normal myocardium. Now, if you listen to cardiac MRI enthusiasts in meetings, you'd think this was an established technique in many cases. However, I would say it's a developing technique. It's very exciting and something that that we should watch for in future. And one of the reasons why it's difficult is it's not really clear what the best methods of acquiring the data is. So different people use different imaging sequences for data acquisition, different scanners. Accessibility to this test is still pretty limited. Your average clinical MRI scan won't include T1 mapping, and it really takes a centre quite a long time to build up expertise to be able to do this. So the normal ranges will vary depending on how you acquire the data, what sort of scanner you're using, and so forth. So you have to spend a period of time, first of all, working out what a normal T1 value in your scanner will be. So for that reason, there's no reference values. Another problem that we're finding is that many pathological disease states, the T1 values overlap significantly with normal ranges, and we need to refine the technique in order to be able to tease out what is normal and abnormal. So amyloid and Anderson-Fabry disease have proven to be exceptions in that the T1 value is so far removed from normal that we can confidently separate them out from normal patients, and that hasn't proven to be the case as we've moved into, for example, looking for early hypertrophic cardiomyopathy and so forth. And finally, what this technique does is introduce new data into the clinical domain that we just haven't had before. So the meaning of this data, how it should impact on patient diagnosis, management, and prognosis really is as yet undefined. So whilst it's very exciting, there's still a considerable way to go with this. So in conclusion, as my time's running out, I'll re-emphasize that echo remains the cornerstone of imaging in heart failure. However, MRI over the past few years has really emerged as a tool that we use increasingly and is now being used routinely for many patients with heart failure. And the reason for that, as I've outlined, is it informs the etiology, it will give you information about prognosis, and it will also guide your treatment. There's been a real move in MRI towards trying to quantify data rather than just visually assess data, and that's really being led by the field of T1 mapping at the moment. But what's really lacking, and hopefully will change over the next couple of years, is trials which will show an effect on patient outcomes. So by managing patients in this way and by imaging them with MRI early, that will make a real difference to patient outcomes. Thank you.